Welcome to PAMED Talks, a podcast brought to you by the Pennsylvania Medical Society. I'm Mila Merkel, PAMED's Director of Communications, and today I'm joined by PAMED Board Chair, Dr. Lorraine Rosamilia, for our Legislative Corner podcast series. Dr. Rosamilia is a board-certified dermatologist practicing with Mount Nittany Health in Center County, PA. She's been an active member of PAMED for 14 years and also currently serves as a delegate to the American Medical Association. Throughout her career, she's been a strong advocate for patients and for the practice of medicine at both the state and federal level. Dr. Rosamilia, welcome.
Thank you.
So today we're diving into an often talked about but still often overlooked issue of access to rural health care across the country, but here in Pennsylvania as well. Oftentimes, the fix for access to rural healthcare in communities across PA includes expanding scope of practice with other healthcare workers. But what are the real issues facing access to care in these communities? How does it affect not only patients, but physicians who practice as well? From workforce shortages to private equity, from Medicaid reimbursement to the bottleneck of medical education, it's all connected, and it's reshaping the future of rural health. So let's get into it. So let's start off. When you look at rural healthcare today, what stands out as the biggest challenge in retaining and recruiting physicians?
I think that's a great place to start because I think everyone, not just physicians, certainly have been taking stock since the pandemic to say, where should I work? Should I be working? Is it somewhere stable if another pandemic would come, or if there's something that would rock the boat in your particular field? Are you in an office or a system that's in the black? Would you sacrifice being part of a system to, for some of your autonomy? Are you going to join somewhere that is smaller? Is it bigger? Will there be more administrative work? Or there'll be productivity quotas that sort of outweigh what your clinical time and judgment might be valuable for? Are there restrictive covenants? Will you feel stuck if you pick a certain line of work or certain system? Do they have a monopoly in an area where you may or may not be able to move if you change your mind? And, from a personal level, which is really what we should mention first, but I think we're kind of programmed to talk about the business first, is where do you want to live? Where do you want to raise a family or be with your loved ones? Does that fit with loved ones' jobs? Where I live, sometimes we really want to recruit physicians or nurses, but say their spouse or loved ones or children have other regions that they need to be in for their education or their jobs. Can you repay your loans? Do you want to retire early, or do you feel like you want to because of some of the shifts in healthcare in terms of technology or in terms of consolidations? And I think that all of those questions are something that we ask when we say, okay, in this new, we call like neo-COVID era, what do we want to do? And, if you do choose to practice in a rural area, will you be really overwhelmed? Because if you are kind of the lone wolf in an area trying to sort of reinvigorate either your specialty or a certain patient population, will you have the resources to do your job well? And I think another overreaching and overarching theme is that a lot of people in healthcare are deciding to do non-clinical work because they may want to get out of, sort of the hamster wheel when it comes to some of the documentation, some of the administrative work, some of the insurance barriers. And there's people who are taking cash only or deciding to be consultants or working for pharma. And although people need to be in all of those positions, we're finding that makes the pipeline and the progression of healthcare worker, evolution to be something that has stalled out. And, when healthcare workers say, okay, where am I going to work and what am I going to do? That's kind of like a you problem, a me problem. But what about the patients? What's the they problem? It's that, do you want to stick to your core and say, who gets care? Will I be working for a practice that takes, say, Medicare and Medicaid? Will we be taking care of actually the people who have the majority coverage in that area? Will you be able to see people who actually get sick, or does that practice not take them anymore? If rural hospitals are closing, if your patients are sick, will they have somewhere to go? Does it feel overcrowded in terms of how patients get acute care? And really, when it comes to positions for training, will you have a pipeline when you decide you want to kind of, fade out in terms of retirement or change your clinical work? So end to end, do we think rural comprehensive care could possibly be a thing of the past? And I hope not.
Wow, yeah. So one thing that you mentioned that I just wanted to see if you wanted to elaborate on a little bit. I know you had some personal experience with restrictive covenants and how that affects how you practice and just how you live personally. Did you want to talk a little bit more about that?
Sure. I worked for a large system for 14 years and resigned 2.5 years ago. In that original contract that was, 2009 or so, a restrictive covenant existed that was 2 years for 30 miles, meaning you cannot work within a 30-mile radius of your practice for 2 years. And laws have changed since then where they can be or should be limited to 1 year, but no mile restrictions. So there's still restrictive covenant barriers in Pennsylvania. In my case, certainly I want to live, work, and raise my family in Center County. We've been there for a while. So basically a system can kind of dictate where you see patients and sort of, in my view, kind of take ownership of your patients, even if you're the one that wants to change your employment situation. In rural areas, when that happens, basically your return patient population, which is thousands of people, now have not a home to go to when it comes to either their primary care or their specialist. And the word, non-compete, it means the system should be able to take those patients and take good care of them. In rural areas, that's rarely the case. They are taking ownership of those patients, but not necessarily promising that they'll have care. Yeah. So that's from a patient standpoint. From a physician standpoint, it means you have to commute if you still want to live in your area. So I commuted for 2 years, an hour each way to a very rural practice, which gave that rural area access to a specialist, but took access away from my prior patients or made them travel too. So I think that it's another facet to why it's difficult in a rural area to be able to pick a system or a practice or a job without looking at kind of the crystal ball of can I live here? Will this be sustainable?
Sure. Well, thank you for sharing that. That's tough. Yeah, for patients and for physicians as well. So I just switching gears a little bit. Let's talk about like residency programs and that sort of shortage. How does the shortage of residency slots in Pennsylvania affect this pipeline, this rural physician pipeline?
So in PA, certainly there are residency slots, a lot of training programs throughout the state, more of them concentrated in the urban areas. When it comes to primary care, which usually kind of sets the tone for physician workforce in an area, there's about 350 primary care residency slots in PA, but we lose about 45-50% of those after they're done with their graduate medical education to other states or other places in general. And it harkens back to a policy for graduate medical education for a cap on the number of slots that started in or was implemented in 1997. I was a senior in high school. And so it limits the number of teaching hospitals who receive reimbursement from the federal government, from Medicare. And, that means that no matter what's happening in a region, it's really not adjusting for needs that are specific for, say, a state or a rural or urban population. And so we actually have increased medical school enrollment, but not increase in residency slots and especially primary care. So what we want for the ones that do exist is to have rural training tracks, improving the pipeline and the experience for people that go to a rural area, because often, even if they're not from there, don't have knowledge of those areas, when they do practice and develop a return patient population, that a lot of them see that there's value in staying and growing their career in those communities. So that bottleneck exists where, trainees and then graduate training and people staying has become a real crunch. But what that leads to is some good and bad things. Basically, there's non-traditional paths that open up for people where even private groups start residencies. If they're privately funded, some of them are awesome and they fill a need for an area that just doesn't have training, but also some of them kind of focus in areas where perhaps the need isn't necessarily there, or it's kind of, becoming a pipeline for their own practice. So you can't really mark on a map that those will go to kind of underserved areas. So when it comes to, again, a lot of patient access issues come from not having a quarterback on their team that tell them, okay, this is an outpatient issue, this is an inpatient issue, this is an emergency issue. If you lose your primary care physician or you lose access where, say, non-physician providers are kind of filling gaps in areas, sometimes that acuity and complexity in places where people don't have access is the real problem. And then that leads to actually a patient needing more visits. So training at kind of the grassroots level is something that still hasn't been settled on solid ground in these rural areas.
Yeah. So we've seen several hospitals close in Pennsylvania, including those tied to private equity. What happens to the rural community when hospitals shut down?
Yeah, I think that most people could answer that question in a similar way, to say, what a shame, and say if I, or a family member or a loved one or anyone says, well, I need to get stitches or I need to deliver a baby. If you need to drive farther for that to happen, that means care quality decreases. And so certainly we don't need a hospital in every corner. And I think the myth is sort of that, okay, inner cities, et cetera, have so many hospitals, it must be so easy to get care. But there's hospitals in cities and in suburbs that are closing. So Crozer is one example. And, in the numbers, surrounding that particular hospital is they have about 400 beds, 25,000 admissions a year, 75,000 ER visits a year. So you're losing a lot of levels of care. So certainly acute care, maternity care, like we said, the ability to have people stay overnight. My local hospital in Clinton County, where I grew up, no longer has a hospital, but it's sort of like a pass-through. They don't even have beds that you can spend the night in. It's sort of a place where they, like a train station, like you decide where they're going to go. And again, that's not going to be a great opportunity to, say, give birth or need surgery. And so, those travel times for patients become just the formula for a worse outcome. And so, the neighboring hospitals definitely, feel that burden, which means that, a patient's traveling farther, their issue is more severe. They may be understaffed for the amount of patients that sort of exploded when somewhere like Crozer closes. My sister-in-law is an RN, and she was working on an inpatient unit at Jefferson, and she said within 2 days of Crozer closing, they felt the burden, not just burden, but they felt the increased workload, the increased number of patients who need them. The statistics are the statistics, but these are people. And the people are the nurses, the people are the doctors, but also the people are the patients. They may be in a neighborhood or a way of transportation they've never taken before to try to get care. And if they're in the ER 6 extra hours or 16 extra hours, or they need a unit that has no beds, or nurses are working double shifts, et cetera, you're finding that quality and the ability for everyone to want to stay in their job and do it well, and even the experience for the patient, if they have that and say, well, I'm not even going to bother next time, and I think that's a real problem. When somewhere like Crozer closes, I mean, you step back and you say, well, why? And some of it has to do with private equity. So, private equity is such a broad term. But in the definition of, say, business, basically it's seeing a business issue where a hospital is closing because, there are insurance reimbursement issues, or there is cost of living issue, cost of products issue. And if they're in financial trouble, businesses see that as an opportunity. And some of that is great opportunity. It depends on who's at the helm. If you can consolidate or bring a group together that can look at the patient as the core of what their goals are, then that's something that actually could save, practices or hospitals. But if you basically see it as just a business and that you churn through and people may or may not want to stay in that job, you may find that when that closes, nothing picks up the slack, in its place. And so what we're finding is that, you don't have senior leadership sometimes in these positions that are healthcare providers, or you see that the reimbursement is just a game or just a negotiation, and that if smaller groups leave or close or get consolidated, you're not leaving something in its path, to take care of those patients. And so you find that, and I'm seeing this a lot, that you could be on a unit in a hospital or an office where the senior nurse or senior, physician has been there for 2 years, or they've been in lots of different places. And although they're the senior person by education, no one's staying in their jobs quite as long because the situations are changing so often. And so sometimes that means, when consolidation happens, it's also less pay for everyone. You're seeing that you're kind of having to spread out the resources, but also bring it together, again, in a place where patients would have to travel farther, where you're seeing people kind of working and living in places where maybe it wasn't their choice. And you're seeing sort of the man behind the curtain of, how are we keeping the lights on? And is this business model might win and it might keep the lights on, but are the people, are the patients, are the workers winning? And winning means healthy and happy, and I wish that wasn't an afterthought.
Yeah. So how do low Medicaid and Medicare reimbursements shape the reality of healthcare in these rural settings, these communities?
So in any practice, you look at an area and what the percentage of Medicaid and Medicare patient population is, or who they serve. And in rural places, that balance is more, that percentage of Medicare and Medicaid patients is more than it is, say, in a suburban area. When you look at the graphs of how Medicare and Medicaid have reimbursed for services, they've really plateaued out over the last 20, 30 years. And that not only plateaus out for what you're reimbursing for services, but it's also what Medicare and, also Medicaid ends up paying a practice or a physician team, not a physician like their salary, but basically saying, okay, per visit, what can we negotiate with this practice for services? And if that keeps either plateauing or going down, but cost of living, gas is $4+ a gallon, that you'd say, okay, this is not sustainable. How would we possibly keep a practice open? And a lot of private practices these days will have a screening call, for the patient before they come, and they might be on the schedule, or say, what's your insurance? What kind of services do we think we're going to, undergo when you come? And sometimes that leads to the patient never being scheduled. Or, it may happen in a hospital system where you say, well, we could admit you. There are laws surrounding giving someone care versus not giving someone care. But if you keep reimbursing less, or the population that you take care of has lesser negotiating power, with those practices or hospitals there, it means that it's harder and harder to do the same services and pay the people who could do it and keep the lights on. And so reimbursement isn't covering the true cost of care anymore. What happens is that there's private groups that then get bought out by, say, private equity, or they consolidate with a big health system. And as we talked about at the beginning, you have to weigh, will you be losing your autonomy? Will you be able to choose how many patients you see a day? Or will just the churning business part take over? Will you be able to keep up with technology? And will you have the resources to hire good staff that want to stay? Or will it be kind of a revolving door, as during the pandemic, where people just kind of hop practices based on bonuses, et cetera? And so what I'm seeing is the practices that are surviving, that are smaller, usually have some other flow of income, because even the commercial insurances are reimbursing less when they see what Medicare's rates are. The problem is if you have a big system down the street that is seeing the same type of patient for the same issue and negotiating a better rate from a business standpoint, you'll always lose. The small groups and say someone's primary care, physician or their team probably won't stick together. And so, you see higher patient loads in areas that still have, say, hospitals and practices, but fewer resources.
Yeah. So we talked about a lot of things, just covering all around rural healthcare. But what are what are the solutions that we've been talking about here in PAMED that have been going on at the Capitol level, or just things that we've come through with like our policy and things that PAMED wants to advocate for that would help to strengthen the rural healthcare communities as they're being affected by these issues?
Yeah, I think it's always great to round out a discussion with not complaining or us having a laundry list of problems, but to really talk about what we can do, because why would we be here? We'd be just still working and seeing patients. And so I think the key to people being involved the word advocacy is very broadly used, but really it means advocating for your patients. It means looking at the political setting, looking at legislation that's passed, knowing the difference between state and federal legislation and what we might have influence on, but also just looking up and saying, okay, I'm gonna look up from my charts I'm doing. I'm gonna look up from sort of the day's work and say, I have the experience and seeing patients and know my community to say that voice is what's needed, on a bigger level. And so Medicaid does have inroads with state government in terms of, our ability to talk about what true payment rates should be for visits, for providers, but also, other practitioners, labor costs, et cetera. There is certainly a crossroads with federal dollars that when they're available, or if there's ways for us to give examples in our own communities about how practices don't take Medicaid anymore, or if there's a percentage of them that we can give those statistics, then I think the real stories are what they need. Certainly, as we talked about, if you expand the number of residency slots, or if you don't have that ability to influence either federal or state dollars for that, try to grow or promote the rural residency programs and the tracks, because there are opportunities there. Because I know as students and residents, as we said, if they see some of these communities and the needs, but also becomes endearing to them that they can be helpful and useful in these areas. And it gives you a different mode of training that you can take to wherever you go, even if you don't stay in Pennsylvania. We hope that they will, but training a pipeline that has just EQ about community medicine or community politics and what happens in legislation makes them useful citizens, in general. And so certainly the rural hospital issue is a constant topic of discussion. I think, the governor's office and, the cabinet looks at that as how can we all come together as physicians, as non-physicians, as nurses, the House of Medicine, business, et cetera, because you can't call, hospitals good or practices bad or private equity bad and insurance good or whatever. It ends up being something that has shades of gray. So you need to have the nuance to have those discussions intelligently with our government. So there are ways that we've had different rural health roundtables and things where we're sitting in the same room as, say, the payers and other practitioners, but also businesses, because we can't live, in a vacuum. Certainly related to rural healthcare is trying to preserve the pipeline where once someone is, done with their training, that they can repay their loans. And so if there's incentives to serve in rural communities, then that's something that certainly will always grow that workforce. And again, grow fondness, hopefully, for the needs and the relationships there. But also to look, again, it's like a they problem, we problem. You have to look at who's been fighting the good fight all along. And if people have gone from paper charts, 40 years ago to still wanting to practice through the pandemic and then want to come out of this unscathed, there are wellness programs for physicians, for teams, for their whole practices to say, okay, there are so many resources that sometimes no one has time to explore, but also even within our medical society, to look at ways that we have support programs for those teams, but also for their mental health, for resources for their practice. And so I think it's all related because, it used to be that the wellness and self-care part was kind of like a soft topic and that people didn't want to talk about it because they see it as just like almost like selfishness. And so we have to change the narrative, but also change the language, because, it doesn't mean like going out and getting a massage, maybe it does, but it often means just having an outlet to say, okay, apart from the exam room or from a hospital bed, there are human beings that have lives that have so many layers. And if you can make their work be something that's meaningful for all those layers, then you retain good healthcare workers in all of the levels. And, just from a practical standpoint, there's telehealth when it comes to, when it comes to visits that are real time, so video, phone, et cetera. There's going to be the e-visits and things where patients can communicate with their doctors off cycle. But it's not replacing your in-person care. But when it comes to access, there's a lot of issues that you have check-ins with patients, especially say elderly patients or people who might not have transportation, to say, okay, normally I wouldn't have an opening for 6 weeks, but in 2 weeks, we can give you a call, or we could set up something where we say, did that all make sense? And sometimes it takes like 30 seconds, and it could be a staff member doing it, or it could be a quick email, or you could talk to their family member that you've, been told to kind of coordinate care with. And that means less, that means fewer resources in the clinic that you need to use to make outcomes better. And so I think all of that is part of seeing the patient, the physician, the nurses, their other team members as people.
Yeah, that's great. Well, bringing it back to our members, is there anything you want to leave with our members with as far as like how they could get involved with advocacy and all the solutions that we highlighted just now, and even just all the issues, if these are resonating with some of our members, how could they get involved?
I think central to a lot of the issues we talked about is looking at many models of care when it comes to physicians and their teams. And so our PAMED president, Dr. Cavale, is leading on June 19th an independent practice summit in Harrisburg. So it's all over our website, but we want to certainly highlight it because looking at different care models, looking at ways to practice that look at kind of this neo-COVID / political / legislative, I guess, influence on the way that we practice, and the way that medical education is structured needs to always be revisited. And so I think this is a great chance for people to see kind of the depth and breadth of that issue. And so it's an in-person conference on June 19th. Also, we have an Advocacy Day for PAMED on September 29th, and that could involve physicians, residents, medical students, even people who aren't members who may want to become members that could participate. And so what that would involve is actually having some sessions where you learn about advocacy and how to do it, in addition to having true visits with your legislators, and some of them will be the ones that are in your backyard and that you may not even know that you have access to. And if you do that in Harrisburg, often that brings the message back to your practice or to your team to say, okay, in our district, what else could we do? And so I think those are really great stepping stones for people who are new to this, but also veterans to say all our touch points, are important ones. So we do have our website as well, the pamedsoc.org/advocacy. So you could use that resource. Our teams there take great care of our members and also are our boots on the ground for discussing things at the Capitol, but also with each other to really speak the language that not only the legislators are speaking, but so they know what's going on, like I said, on the ground in practices and in hospitals.
That's great, yeah. And registration for Advocacy Day will open, I think, early summer, we're looking. So stay plugged into PAMED Communications, and hopefully we get a good amount of members come out and advocate for all these issues. Well, thank you so much for joining us today, Dr. Rosamilia. It's important to keep these conversations in the forefront with all that physicians have been going on. So I appreciate you coming in to give us some insight today.
Thanks for having me.
Thanks for coming.